Okay, so let's talk about vestibular neuritis or MRI of vestibular neuritis. So what we have is a disorder. Usually it stems from a viral infection. Viral infection is the most common cause. It can also be bacterial, but much less common. Most commonly herpes virus, but even though the most common pathology or cause is viral infection, herpes virus, you won't see treatment for viral infection. You won't see acyclovir use. So vestibular neuritis is a inflammation of the vestibulocochlear nerve, usually the superior branch, but can also involve the uh, inferior branch. And when I say the superior and inferior branch, I say it about the vestibular nerve, because vestibular neuritis, as the name suggests, cause damage to the vestibular part of the vestibulocochlear nerve. It's inflammation of this part. Now, this is from Radiopedia, yes? And remember that the vestibular nerve is from the vestibulocochlear nerve. If we look at the images, what you will see in MRI is that usually it is totally a normal MRI. You can see quite normal MRI right over here. But what you are looking for that you may see is, first of all, you need to exclude other causes for vestibular neuritis. Now, what is the clinical presentation that you should think about? The clinical presentation is usually sudden vertigo. It's not. It doesn't must come with the viral infection signs. It can be vertigo that is sudden and severe. Usually, it can be continuous with nystagmus, nystagmus that is peripheral, horizontal nystagmus with fast phase to the healthy side, not to the damaged side. Alexander's law is not exactly what they say over here. Alexander's law say that if you look to the non-damaged side, it is the fast phase is more pronounced, as it's over to here. The amplitude of nystagmus increases with gait directed toward the side of the fast phase. Now the fast phase is to the healthy side. So in vestibular neuritis, if you look to the healthy side, which is the fast phase side of the nystagmus, you, according to the Alexander's law of peripheral nystagmus, Alexander's law is a law for peripheral nystagmus that comes from the inner ear and the vestibular nerve and not from the brain itself. So Alexander Rhodes state that the fast phase will uh, increase in amplitude if you look to the side of the fast phase. Now, because he has damage to the vestibular nerve, which is important for balance, he has vertigo that is sudden severe. He has nystagmus that has the characteristics of peripheral nystagmus. We think about fixation that reduce the nystagmus as peripheral nystagmus. Think about Alexander Law. Think about horizontal nystagmus. Uh, think about those things. And balance and gait difficulty, nausea and vomiting because of this, and concentration problem because of this. The idea is that it's vestibular nerve inflammation, so balance will be damaged and vertigo will be damaged, and the patient will have vertigo, and there will be a peripheral nystagmus that is of peripheral region. Now, usually the vestibular nerve is damaged in its superior branch. It can also be in the inferior, but mostly in the superior because its root or course is more constricted. So usually the superior branch is more involved. Now remember that the superior branch innervates the superior and horizontal semicircular canals. And in MRI, usually you will find quite a normal study. You must exclude other things. For example, think about a 70-year-old patient with atherosclerosis, hypertension, and diabetes that come to the emergency department with vertigo, with acute onset of sudden severe vertigo that is not like BBPV, it's not totally position dependent and not goes after 1 or 2 minutes or even less. So it's not BBPV. And now the, I don't know, ED doc or neurology needs, or the, I don't know, ENT need to think, usually not ENT when you think about a stroke, but need to think about stroke in the differential diagnosis of the posterior circulation, yes, of the basilar artery, vertebral artery, I don't know. So you need to exclude those things in the MRI. You can see here ICA territory, anterocerebellar artery territory that can uh, give rise to the in blood to the cerebellum. And I think that the labyrinthine artery also comes from the ICA, if I remember correctly. I'm quite sure that it's a branch of the ICA. Here it is. This is what I thought, that the labyrinthine artery is a branch of the anterior inferior cerebellar artery. You can see it right over here. It gives rise to the, and approximately it runs from the basilar artery. Usually it comes from the internal auditory interartery, typical of the anterior inferior cerebellar artery. Yes, as we thought. Okay. So MRI, you need to exclude tumors, you need to exclude stroke, you need to exclude things that are much more severe. And say things that are much more severe because vestibular neuritis is usually not a devastating disease in the way that it usually will cause death to the patient. No, it usually quite not nice disease, but it usually quite benign, good prognosis. The patient usually gets better, but it's not life or death. You need to exclude those things that may be life or death. And then after this, the MRI is usually normal in vestibular neuritis, but you may see T1 enhanced with gadolinium, contrast enhanced T1, as you can see here, that when you look, now where should you look? Now, remember that the vestibulocochlear nerve, which is the eighth nerve after the facial nerve, you have the abducens, facial, vestibulocochlear, and glossopharyngeal, vagus. Remember this order. So the vestibulocochlear nerve is the eighth nerve, and it comes from the inferior part of the pons, between the pons and the medulla, there in the lateral side, and goes to the, of course, vestibulocochlear. So it goes to the cochlea and the vestibule of the labyrinth. So it goes to the side of the inner ears. So it's on this side. So look for things that are going to this area. And if you look closely, you will see that here is the pons, here is the midbrain, here is the pons, here is the medulla. And between the pons and the medulla, you will see right over here those two nerves that come and branch here are the vestibulocochlear. You also may see here other nerves like the, I don't know, the facial nerve, but this is the vestibulocochlear nerve. And if you look quite closely on, maybe I should make it bigger. If you look closely on the left side, what you will see is that there is a hyper intense, let's look at the T1 with gadolinium, contrast enhanced. Yes, this one. Now let's go again. We want to go to the, wait, let's go to, this is the midbrain, the pons, and then here. You see right over here, those two are the vestibulocochlear nerve, and in the left side you can see the hyperintense sign. This is the hyperintense as a sign of neuritis. So you can see it right over here. Not all the time you will see it, but again, exclude, I don't know, vestibular schwannoma, exclude in the cerebropontine angle, exclude any other meningioma or, I don't know, astrocytoma or any other tumor or malformation. Exclude a CVA. If you have a DWI, it may help you. We don't have here DWI. Okay, we have T2. Look for something that may help you. It won't really help, but you can see here the vestibulocochlear nerve. Maybe it's a little bit more here hyper intense, I don't know. In the left side, of course, because we are thinking about vestibular neuritis in the left side. Again, Look for the pons, look for the medulla, look between them, and you will find the vestibulocochlear nerve. Okay, and look for other things that may cause a sudden acute, very badly vertigo, and that's it. Okay, this is vertigo in the left ear, pain and tinnitus. Remember that vestibular neuritis, vestibular neuritis, when you are saying vestibular neuritis, usually it can be divided from labyrinthitis, from labyrinthitis if it's only the vestibular part that is affected, and in viral labyrinthitis, to the contrary, you have also inclusion of the cochlear side. So in vestibular neuritis, you should have only involvement of the vestibular nerve, and in viral labyrinthitis, you should have vestibular nerve involvement, the vestibular part of the labyrinth, but also the cochlear part. This is why it's viral labyrinthitis and not just vestibular neuritis. And in usually in vestibular neuritis, you won't expect sound manifestation, no hearing loss, tinnitus less commonly. So saying that there is a tinnitus, maybe you may even call it viral labyrinthitis and not vestibular neuritis, even though he says here vestibulocochlear neuritis. So even if the cochlear nerve is also involved, tinnitus may be there, but usually the name is vestibular neuritis or viral labyrinthitis. Anyway, you see here the medulla, you see here the pons between them, you can see the vestibulocochlear nerve, and you want to see if this nerve in T1 with a contrast. So right over here, you may see that the nerve is hyper intense, as you can see right over here. It's with enhancement in T1. So what do you say? And on the other hand, swelling of both vestibular and cochlear nerve bundles. You see here, if there is a cochlear involvement, you call it labyrinthitis, produce tinnitus and hearing loss. They are saying exactly what I said, so I didn't know why they didn't. So maybe this one they meant to say labyrinthitis, because I see that vestibular and cochlear nerve bundles they call labyrinthitis. Because in vestibular neuritis, less commonly it involved or it should not involve auditory symptoms. So the treatment for vestibular neuritis, it's usually corticosteroids, antiemetic, vestibular physiotherapy, or maybe vestibular suppressant for a short period to help the patient. I don't know, like beta histine, Agiserc, I mean, antihistamines type first generation. But remember that a vestibular suppressant may block or may delay the return to work of the patient because they suppress even not just the vertigo of the patient but also the cure of the patient. But in the start, in the first days, vestibular neuritis or viral labyrinthitis, if you want, depends on which part is involved, is quite bad. It's quite not very nice to the patient, very severe vertigo. So in the first day, the patient may need it. And you see here that even though herpes simplex virus is the most common, considered the most common viral etiology, and viral etiology is most common viral cause of vestibular neuritis, and viral infection are thought to be the commonest cause of vestibular neuritis, even though you won't see treatment with viral or bacteria therapy, uh, and usually the patient will recover and no recurrence will the patient have. And remember the differential diagnosis. Sometimes it is hard, even though the nystagmus may seem peripheral in origin and not central, even though this you need to think about it, the most devastating differential diagnosis: tumors, CVAs in the posterior circulation like basilar artery, ICA with labyrinthine artery involvement. So think about the differential diagnosis. And this is it. Thank you very much. If there are any mistakes or correction, please tell me. And thank you very much. And that's it. This is about vestibular neuritis or viral labyrinthitis, including the imaging. findings.